by Dr. Abarna. Abarna is an alumnus from this institute, and she's now based in Chennai. So she will be talking on treatment intensification in KD in various situations.
Good morning everyone. It's good to be back after 2 months. Intensification in Kawasaki disease, when, why and how. So most of my talk was covered by the previous two talks, but it's okay, I'll try to say things that has not been covered in the previous talks. So we all know Kawasaki disease is a self-limiting disease, and the main issue is the coronary artery abnormalities. And pre-IVAG, we know without treatment, the incidence of CA is around 25%, and with IVAG, it reduces to nearly 5%. So the question is like, does it really reduces to less than 5% in all subgroup of patient or all patient? If we subgroup analysis, the patients who are at high risk, is it always like less than 5%? So that is when we think about this, then primary intensification comes. So there are like a lot of risk factors based on the area in which the person is from. Like US says like different scores and Japan says like different scores, so it varies with topography. There is no standardized risk factor or a scoring system. It varies in the different parts of the world, and the risk factor differs from other countries, especially Japan and India and US and everything. So this is the case that I managed in my last month of SRship, like few months ago. So this is a 3-month-old case who came after vaccination. She had fever for 5 days, she had rash, she had conjunctival injection, lip redness and oral mucosal changes, but in the private practice, the child was only treated with oral cefixime. But later child came with a gangrene and a well-defined rash and peeling. So during the time of admission, we noticed the child had giant coronary aneurysm involving LMCA, LAD, LCX and RCA. So in this patient also underwent a CTCA, which is I have depicted in that slide. So this child had like 2 aneurysms in the LADs and had a giant aneurysm in LCX and an aneurysm in RCA also. So this case, if we see, this child was 3-month-old, so that is also a risk factor, diagnosed late, the IVIG was started late, and in the day of presentation only child had like giant aneurysms. So all these risk factors child had when the child presented with this. So the potential risk factors for CA in KD, so that is when we start with the intensification. So when it's a refractory disease or like resistance, that is like you are reacting later, but like sir told, like preemptively we have to find out what are the risk factors. So these are the like few common risk factors that has been covered in the previous talks also. One is like age being less than 1 year. One is the gender, male gender or prolonged duration of fever, delayed initiation of IVAG, IVAG resistant KD or coronary artery aneurysms, or Z scores more than 2.5 at baseline. So I will be talking about the few studies that highlights these risk factors. So first, age is a risk factor. We all know both in the lesser age group and those in the older age group, both are at risk of developing CAS. So first, Salgado et al. Has studied infants less than 6 months, and he found out like the rate of coronary artery aneurysm is almost as high as like 40%. And there was one more study by Hayan et al. He also studied children who are less than 88 months of age, and they have found that the aneurysm rates are almost around 47.4%. So these are the two, this is one of the group that is age infants, that is less than 1 year. Few says like less than 6 months, few says less than 8 months, and different studies says different age group, but definitely a less than 1 year is a risk factors for developing coronary artery aneurysms. So I have not highlighted one of the article that is from our institute regarding the older age group. I think Deepti ma'am has highlighted that article. So in that study, in the older age group, they have mentioned like coronary artery aneurysms almost around 15%. Coming to the next thing, that there are scoring systems like Kobayashi score, which says IVAG resistant. This scoring system does not predict the risk of coronary artery abnormality, but predict the risk of IVAG resistance. So we always say like when there is an IVAG resistance, there is an increased risk of coronary artery abnormality. But nowadays there are studies which are coming up which says like which tried to predict the scoring system for coronary artery abnormality, which I will be discussing in the subsequent slides. So these are studies from various parts of the world, which talks about the coronary artery abnormality, the risk factors for coronary artery abnormality. So there are few factors which are common, including the duration of fever, that is like more than 6 days, few is more than 10 days, and definitely age, like I said, less than 1 year is a risk factor, and also the higher the age group is also a risk factor. The day of IVAG infusion, the delay in the IVAG infusion, definitely the increased risk of coronary artery abnormalities. And hemoglobin less than 10 has been found to be a risk factor for giant coronary artery abnormalities. Thrombocytosis, that has been mentioned in studies from Croatia and Spain, being a high risk factors. IVAG resistant refractory diseases, recurrent diseases, coronary artery aneurysm diagnosis, atypical KD. So all these are the risk factors that they have mentioned. So this is from post-RISE trial. So in which they have mentioned like independent predictor for coronary artery abnormality. They mentioned like 3 factors. The one is like the baseline Z-scores being more than 2.5, age of onset being less than 1 year, and non-responsive to IVAG plus steroids. The significant independent risk factor for IVAG resistance are the Kobayashi score and baseline total high bilirubin levels. So these are the independent risk factors that they have mentioned for the development of CAAs and IVAG resistance. So this is the SUN score, I think, which has been covered by both both of my previous speakers. In the statistical analysis, they have found the 4 risk factors, that is like baseline Z-score more than being 2, age of fever onset less than 6 months, Asian race and CRP, in which the baseline Z-score more than 2, they have given a scoring point of 2, and the rest of the 3 criteria, they give a score of 1. So in this, the low risk factor is 0 to 1, moderate risk factor is 2, and high risk is 3 to 5. So this scoring system, they have developed using a development data set, and then they have validated. In the developmental data set, they have found that the odds ratio of CA is 16-fold higher if they have a high risk factors. That is like when the scoring system is more than 3 to 5. But in the validation cohort, when they found like in the high risk scores group, it is more than 40-fold increase risk of CAA. So this is the article that Sir was talking about when just before introduced us, the subgroup analysis by the Jane C. Burns group. So they have done a cluster analysis involving a 14 variable, and they tried to analyze the proteomics and the geographical and epidemiological data behind it. And then they have clustered it into 4 groups. The 4 groups are the one with the liver, one with the band shape, one with the node, and one with the young group. So the young age at onset patient, if you see, they have the increased risk of CAA. Even though the IVAG resistance rate, they have mentioned like it is low, but they found like that those patients have like high platelet count, high lymphocyte count, and then they have high risk of CAA. The other group that I want to highlight is the one with the liver group. So the one that has like high transaminases, high bilirubin levels. Even though they are older age at onset, they have like high risk of IVAG resistance. So these are the 2 groups that I want to highlight, because like these 2 groups needs to be intensified with treatment at the onset. The other 2 groups that I have mentioned is like high band neutrophil counts. So, and the other one is the cervical lymph node group. The lymph node group has like intermediate risk for like CAA, IVAG risk and KD shock. But the band shape group, those who's having increased band neutrophils have like high risk of KD shock syndrome. So these patients also will require an extra treatment at onset only. So this study I want to highlight. So this is like we have talked about Kobayashi scores, Sano scores, Igami scores, and everything. All those scoring system for IVAG resistance. So this is one of the scoring system that has been published recently in 2024 from China. So they have also had like a development data center and a validation data center and tried to make a scoring system. And this is a very complicated study, and they have derived such a complicated scoring system. So they have developed the scoring system for 2 groups. One is like medium or giant CAA group, and then for a CAA group. But I just want to highlight the factors that they have talked about. One is like male sex, age, total duration of fever, IVAG resistant platelets, and hypoalbuminemia. So in this, based on the scoring system, in the developmental set, they have found a sensitivity and specificity of around 86.9, and specificity of 81, and in the validation group it is also like almost more or less similar, that is little more than 80. And in the giant CAA group, they have again did such a complicated scoring system. But the factors they have, there are like few factors that is extra compared to the medium group. That is like the one is the hemoglobin they have added. That is low anemia is a risk factor, and ESR being higher is also a risk factor. So based on the scoring system, they have told like we can predict the giant CAA with a sensitivity of almost around 90 to 80, more than 85%. So coming to the other risk factors apart from the IVIG resistance and CAA, so there is macrophage activation syndrome is also a risk factor for development of CAA and having a severe disease. So a study from our unit only by Dr. Rakesh, they have mentioned like the CAA in the group with macrophage activation syndrome is almost around 41%. So the next group is like atypical KD. So atypical KD, why it is important? Because it is always difficult to diagnose KD at the onset, and there will be delay in the diagnosis, and these patients have high risk to develop into coronary artery abnormality or IVIG resistance. So in this study, they have mentioned like in atypical KD, the CAA development is almost around 64%. So this is also one of the group which needs intensified treatment. So this is updated guidelines of 2024. So they have mentioned like three things. One is like sun risk score, and apart from the baseline CA is more than 2.5 and infants less than 6 months. So these are the things they have mentioned. These are the patients that they have mentioned as high risk group for intensified therapy. So I have almost covered when do we need to have a primary intensification, that is like age, both the extremes, atypical presentation, severe forms, those with macrophage activation or shock syndrome or IVIG resistance, or the scoring system for both CAAs and IVIG resistance. If we put, then we have to hit hard at presentation itself. So why do we need to intensify in the beginning? So the goal of the treatment is like not just, one is like main is to prevent CAA, and then to have like long-term subclinical endothelial dysfunction we have to prevent. So we need to intensify for those patients with the high risk that I have mentioned in the previous slides. Coming to the treatment part, I think the treatment part more or less the drugs and the studies have been covered. So this slide has already been shown by Dr. Abe. So from the time that we thought initially prednisolone was not useful, then RACE trial, landmark trial like RACE trial has shown like prednisolone has been useful, and later there are trials for infliximab and cyclosporin and anakinra has come up. But the thing is like all these studies, even the RACE or KAIKA, all these studies, they classify patients based on IVIG resistance scoring system and then they intensify. There is no study which classify based on the high risk for coronary artery development and then they treat it. So I just quickly brush through the studies for steroids. So this is by Diana et al., in which they have found that with the steroids or infliximab, the CAA risk has been reduced to 23%, when if we use IVIG only in the high risk group, it was around almost 50 to 60%. And as for steroids, there is Cochrane review in which they have mentioned like steroids are better in reducing coronary artery abnormalities and reducing inflammatory markers, and there is shorter duration of hospital stay. And this is a RACE trial, like it's been talked so much in the previous talks, in which the CAA risk has been reduced from 23% to 3% if we have used prednisolone along with it. In this, they have mentioned like you used 2 mg per kg of prednisolone for 5 days and then taper it over the next 15 days. And infliximab, this has been widely used in USA, and then the studies are from Tremolay et al. And KitCare, and they have also found that infliximab reduces LAD, Z scores, and then the reaction rates of IVIG has been reduced, and the need for additional therapies has been reduced. And coming to the role of cyclosporin, and the cyclosporin has been widely used because we know that two commonly involved genes like ITPKC and CASP3, which involves the NFAT and calmodulin calcineurin complex. So cyclosporin inhibits it. So they started trying cyclosporin. The important trial is the KAIKA trial, which has been mentioned previously. So I'm going to skip through. So this is the one important trial that they talk about is like these in the KD CAA prevention trial that's still going on from UK. So the inclusion criteria that they have mentioned is like any patients who's been classified as KD as per AHA, both complete and incomplete KD. So the exclusion are the one they have diagnosis it's very doubtful, or like CA at presentation, or like any other cardiac manifestation at presentation, or suspected macrophage activation syndrome. So this patient, like just with KD that we are diagnosing without, like they have not talked about the risk factors like rest of the trials like RAISE or KAIKA or anything. So this is like just KD patients, they are giving IVIG plus steroids in one group and IVIG in the other group, and they want to see the, as a primary endpoint, how many of them has like CAA. So this might help that whether steroids is really helpful in patients with preventing coronary artery abnormalities. The study results are still pending. So the thing is like we talked so much about so many different drugs. So we know it will reduces the incidence of CAA, but in high risk infants, how much it is going to reduce? That is a real question, which we still don't know. In patients who are like high risk infants, like when CAA incidence is almost 50%, we don't know how much it's going to come down. So this is AHA 2024 guidelines, which shows the drugs that I think it has been previously covered. Prednisolone, methylprednisolone, infliximab, etanercept are the drugs that they have mentioned for intensification. Anakinra they have mentioned for additional therapies who are refractory to therapies. And this is a study from our institute. In this compiled the risk factors for intensification, and the drugs that has been used is like either IVIG, infliximab, steroids, or cyclosporin. In cases that are needed, we can use all of them. So this is the treatment that we have used for the case that I have initially mentioned. So we manage the case using, we give an IVIG, we gave infliximab, we have steroids, and we gave cyclosporin also, but still the child had persistent myocarditis, so we ended up giving a second dose of IVIG with 1 gram per kg. Finally, the child got discharged. So I conclude by saying we have to identify the risk factors, and there are a lot of risk factors. And treatment, it depends upon the countries and our expertise, and there are a lot of drugs that we choose, and sometimes we ended up giving multiple drugs. Thank you so much.
Thank you. So we have questions at the end of the 3 talks. The next speaker is Dr. Munish Arora, and he will be talking on Kawasaki disease shock syndrome, a condition that is often missed or diagnosed very late, and a condition where again the chances of complications are very, very high.
Thank you, sir. I would like to thank the organizers for giving me this opportunity. My talk will be on Kawasaki disease shock syndrome. So by definition, Kawasaki disease shock syndrome is a rare but severe form of Kawasaki disease in which patients present with vasodilatory shock, hypotension, and poor perfusion, with or without myocardial dysfunction. So going to history, it was first recognized in year 2008 by Dominguez et al., who reported 14 patients with KD who had hypotension and required management in ICUs. Then in year 2009, Kanegai et al. Introduced the term Kawasaki disease shock syndrome first time to distinguish this entity from the hemodynamically normal Kawasaki disease. What they found? They found that patients who had this syndrome had more severe laboratory markers of inflammation, and they were having greater risk of coronary artery abnormalities, including mitral regurgitation and prolonged myocardial dysfunction. Incidence of Kawasaki disease shock syndrome is different according to different literatures. In Mexico, it's 5%. Chinese report it to be around 1.2%. In our publication from PGI, we report the incidence to be around 3.4%. So definition was given by Kanegai et al. He defined Kawasaki disease syndrome, shock syndrome, as sustained presence of any one of the following conditions: either systolic hypotension for age, decrease in systolic blood pressure from baseline of more than 20%, or clinical signs of poor perfusion not accounted for by other conditions. All these would require the treating clinician to initiate volume expansion or infuse vasoactive drugs or transfer the patient to intensive care subunit. The etiopathogenesis is multifactorial. There will be some factor of vasculitis which will lead to cytokine dysregulation leading to capillary leakage and myocardial dysfunction. Coming on to clinical and laboratory features of Kawasaki disease syndrome, shock syndrome. This was a study done in China, published in 2019. They recognized patients of Kawasaki disease syndrome from January 2014 to October 2017. 2023 patients of Kawasaki disease were enrolled, out of which they recognized 27 patients of Kawasaki disease shock syndrome. 43 patients of Kawasaki disease who didn't have KDSS were chosen as control. What they found that patients who had Kawasaki disease syndrome, the mean age of diagnosis of Kawasaki disease or onset of Kawasaki disease was more than in patients of Kawasaki disease without shock syndrome. Also, they recognized that these patients had more days of fever, or the diagnosis of Kawasaki disease was made late. Approximate mean age was 10 days, on 10th day of Kawasaki disease. The other signs of Kawasaki disease like conjunctival injection, oromucosal changes, or lymphadenopathy, it was not significant. Mainly mean age was older and mean duration of fever was more. Laboratory features, the patients of Kawasaki disease syndrome had more WBC count, they had higher polymorphonuclear cells, hemoglobin was low as compared to patients, normal Kawasaki disease patients. Other significant changes or significant p-value was that they had higher CRP value, low albumin count, low serum sodium concentration. The Kawasaki disease shock syndrome is multi-organ. So the patient also had higher creatinine, higher blood urine nitrogen, involvement of myocardial dysfunction was recognized by higher CKMB value. D-dimer was raised in these patients and procalcitonin was also raised. They did serum cytokine levels in normal patients. It means that Kawasaki disease patients without shock and Kawasaki disease shock syndrome, the IL-6, IL-10 and interferon gamma, they all were highly raised or significantly raised as compared to patients with hemodynamically normal Kawasaki disease. Coming on to treatment and outcome measures in KDSS patients, these patients had significantly higher rate of coronary artery abnormalities. These patients also had more chances of aseptic meningitis as compared to hemodynamically normal Kawasaki disease patients. As expected, ECG abnormalities were more in these patients. These patients also had significantly raised IVIG resistance. They needed second dose of IVIG because of resistance, and also organ damage, other organ damage which include CNS and renal were also more in patients with Kawasaki disease shock syndrome. This was another study published from USA by Kanegawa et al. They recognized that majority of the patients who had Kawasaki disease shock syndrome as compared to without shock were Hispanic in ethnicity. Also, as mentioned by Dr. Aparna, band forms were more, neutrophilic band forms were more in patients with Kawasaki disease syndrome, shock syndrome. They had a significantly low value of platelet counts as compared to patients with hemodynamically normal Kawasaki disease. CRP was higher, and the patients also had IVIG resistance as compared to patients without shock. Coming on to cardiac manifestations, the patients with Kawasaki disease shock syndrome had more chances of coronary artery abnormalities, which included dilatations and aneurysms. They also had decreased ejection fraction as compared to Kawasaki disease without shock. Chances of mitral regurgitation were more in patients of shock. So they concluded that compared with hemodynamically normal Kawasaki disease, KD shock syndrome is associated with increased inflammation, more platelet consumption leading to thrombocytopenia, IVIG resistance, coronary artery abnormalities, mitral regurgitation, and myocardial dysfunction. Coming on to our experience, this was published as an abstract in ACR meeting 2019. Cases of Kawasaki disease from January 1994 to December 2018 were enrolled in this study. We recognized 810 cases of Kawasaki disease. 28% or 3.4% of patients had Kawasaki disease syndrome. Majority of patients were boys. Median age of diagnosis was 7 years. And all the patients of shock required inotropic support. IVIG was given to all of these patients as it is a standard of care. 3 patients required additional management with infliximab, 2 required second dose of IVIG, and 4 patients were started on steroids. 5 patients had coronary artery abnormalities. Out of all these patients, 1 patient succumbed to the illness. There is an overlap of Kawasaki disease shock syndrome with toxic shock syndrome. There is a role of superantigens in Kawasaki disease shock syndrome also. And in 7-month infant who was autopsied when he expired due to Kawasaki disease shock syndrome, it was found that there is selective expansion and infiltration of variable beta-2, CD4 and CD8 T cells in the myocardium and coronary arteries of that infant. This variable beta-2 region is independent of T cell receptor and it is activated only by superantigens. So superantigens play a role in pathogenesis of Kawasaki disease shock syndrome, but not in hemodynamically normal Kawasaki disease. So we have to differentiate patients of Kawasaki disease shock syndrome from toxic shock syndrome because there is an overlap in clinical scenario in both of these syndromes. The patients with Kawasaki disease shock syndrome will be younger as compared to patients of toxic shock syndrome, but it doesn't mean that Kawasaki disease shock syndrome cannot occur in elder patients of Kawasaki disease. Kawasaki disease shock syndrome patients will have a lower hemoglobin as compared to TSS patients. They will have more coronary artery abnormalities, more chances of regurgitation lesions which will be caused by valvulitis, and they will have elevated thrombocyte count as compared to patients with toxic shock syndrome. Otherwise, fever, rash, oromucosal changes, eye changes can be similar in both. It is a differential diagnosis of KDSS and toxic shock syndrome. For management, as highlighted by earlier speakers, Kawasaki disease shock syndrome, we will need to intensify the treatment, either primary intensification whenever we recognize the patient to be having Kawasaki disease shock syndrome, or secondary intensification when the patient of Kawasaki disease, otherwise not being intensified with treatment, develops shock syndrome. Standard Kawasaki disease treatment is followed, IVIG with aspirin. Shock will be addressed with the fluid resuscitation and vasopressors. Repeat dose of IVIG or steroids or other immunomodulator drugs, anakinra, infliximab or cyclosporin will be needed as center preference, as per center preference will be needed. Plasmapheresis has a role in Kawasaki disease shock syndrome. So my take-home messages will be whenever we get a call from ICU or PICU or any other intensive care unit for a patient of shock, we should also keep a possibility of Kawasaki disease shock syndrome. We should also keep a possibility of KDSS in a patient of toxic shock syndrome as a differential. As compared to hemodynamically normal Kawasaki disease, KDSS patients are older in age. They have a prolonged duration of fever, more WBC count, more neutrophils, higher inflammatory parameters, so CRP, ESR, procalcitonin, higher D-dimer values. They will have lower hemoglobin and albumin. They will present as a severe case of Kawasaki disease with hyponatremia, hypokalemia. They will be refractory to IVIG, presenting with more coronary artery abnormalities, and aseptic meningitis is more likely to be seen in these patients. They will need aggressive treatment including repeat IVIG or steroids or immunomodulators as per center preference. Thank you.
Thank you, Manish. Now now we have Dr. Pallavi Nadi, and she will be talking on another subgroup which requires intensification, that is KD in infants.
Thank you, sir, and thank you, organizers, for giving me this opportunity to come back as a faculty, which is exciting thing for me. So, thank you, sir. Today, I'll be talking about Kawasaki disease in infants. Initially, if you glance at the topic, it seems like a very small topic. However, one can understand why it has been given 10 minutes for discussion in this forum. So, Kawasaki disease below 1 year of age can be very challenging because they have very atypical type of presentation, and most of the times it's very difficult to clinch the diagnosis. Usually there is a delay in diagnosis as well as treatment. So let's start with the few cases that I saw during my residency. So this was a 2-month-old girl child, symptomatic since 1.5 months of age. She initially developed high-grade fever, some rash over the body which resolved, and then it developed into some verrucous type of lesions. And over the time, she became very irritable, she was very tachypnic, so a possibility of a sepsis was considered from the referring hospital. They gave multiple antibiotics. So she came to emergency. Our initial possibility, because she was a 1.5 month to 2 months old baby with something which looked like pneumonia. So initially our diagnosis was also swept us away from Kawasaki disease. We were thinking more of Omen syndrome or a LCH, something like that, until we saw this. We saw that the child was keeping the hands closed, but when we opened it, we saw that there was some desquamations. This was on day 2, day 3 during the admission. However, on day 1, it was very subtle. So this led us to think about Kawasaki disease, and then we did an echo which showed a large aneurysm in LAD as well as in RCA. So we treated this child with IVIG and steroids, infliximab, cyclosporin, and we also gave her enoxaparin. And finally, when she recovered, there was no rash. The nails had started showing Bose lines. So this second case is probably, it has got repeated multiple times in the last 3-4 days. But this also was an infant who presented at 5 months of age, probably 4.5–5 months of age, with fever, maculopapular rash, some redness which developed during the course, swelling around the left side of neck, possibly a lymphadenitis. He was treated elsewhere with oral antipyretics and antimicrobials. He continued to have fever. He developed more symptoms of failure. So that was when something like viral myocarditis was thought of, and child received IVIG. This was during the 4th week of illness. And then when he went for a follow-up at 10th week, the echo showed there was some dilatations of the coronaries. That was when the referral came to PGI. So this was possibly a Kawasaki disease which was missed in the initial presentation. So we also did the echo. We saw that there was a large aneurysm in the LAD with a thrombus which sitting over there, and his inflammatory parameters were still elevated. So we acted upon and gave him other medications like repeat IVIG, infliximab, and also gave him cyclosporin. So these two cases highlight why it is important to know that Kawasaki disease in infants can be different, and it can be, presentation can be totally atypical and incomplete. It has been seen that the incomplete presentation is seen in about 19 to 80% of the children, and diagnosis is definitely challenging because of this unusual presentation. So let's understand about the epidemiology of the Kawasaki disease in infants. Recently, there was a paper published from Japan about the epidemiology of these kids. They collected all the cases from the inception till 2019, before the pandemic. They had about 3 lakh cases, out of which 28,000 were less than 6 months of age, which constituted 8.7%. So when they charted the number of cases over the years, they saw there was a surge, there was epidemics 3 times during early and mid 1980s. during that time, there was a surge of other age groups, that is 6 months to 5 years. However, the two age groups which had very slight increase in case only were less than 6 months, that is the infants, and and more than 5 years, the older kids. Over the next few years, from 1985 to around 2002, there was a steady increase in cases of in all the age groups, and following 2020, probably because of earlier detection and more detection, there was increase in cases of all the age groups. However, if you see the curve of the infantile Kawasaki disease, it is more or less has been stable, and even though there has been decreasing, like in age above 3 years of age, the increase has been more than 5 times. However, in infantile Kawasaki disease, there was increase in only 2 times, factor of 2. And there had been major decrease in incidences, mean incidences. One was in 2016 and 17, other was during the COVID-19. So the other age group saw a decline in cases during those time. However, there was no such decline in incidence of infants presenting with Kawasaki disease. This also opens a Pandora box of questions like what could be the reason for such decline in only in adults, but there was not much of decline in cases of infants with Kawasaki disease. So is it a different etiology? Is it a same etiology? If it was the same etiology, why there was no increase during the epidemics? Also, when they observed the seasonal variation of the infants with Kawasaki disease, they found more or less a stable incidence over the months, with a slight peak in the months of June and August. However, in the other age groups, that is more than 6 months, and in the age group of 2 and above the 3 years, there was a significant surge in winter peaks, that is during the January and December in Japan. However, there was no such peak seen in infants. So again, possibly the epidemiology of is different, and possibly pathoetiology may or may not be different between the infant and older children. So is it because of the social factor that the infants less than 6 months are mostly kept at home, and more than 6 months they go to daycare or they go to school, and that's why they are exposed to various environmental factors that could be etiology or trigger for Kawasaki disease? Or are those infants who are at home actually developing Kawasaki disease because of the other older sibling who have other environmental exposures, or the trigger is different for both or is there a genetic susceptibility? Again, we don't have answers even after so many decades of the description of the initial disease. So if we come to South Korea, again, in South Korea also, there is a higher proportion, about 7.6% of children are less than 6 months of age. They also checked the difference in presentation between the two. They saw that coronary artery abnormalities of any kind and aneurysms were much higher in children less than 6 months of age when compared to the more than 6 months of age. They also compared whether there was any difference in male and female. Once the children are less than 6 months, they are just high risk. You do not have like male have got higher prediction for coronaries, or females have got higher. There is no difference such as. Once they are in high risk group, they are in high risk group. This is what we can take from this article. So from India, we have to know our own data as well. This is from PGI Chandigarh. So we have about 3.6% of children who are below 6 months of age, and about 88% of them have been incomplete presentations, and 35% of them actually developed a coronary artery abnormalities in follow-up. And there was a significant delay in diagnosis of more than 10 days in 12 of our patients, which constitutes 70% of our patients. So this actually shows that possibly a lot of cases of Kawasaki disease are missed because of the incomplete presentation. They may not actually reach to the centers where they can find treatment for this, and also because of this delay, there is a higher risk of coronary artery abnormalities in these kids. So moving further towards the west, that is there is a article from Italy, which show that they have about 1.7% cases who are less than 6 months, and 28% of their cases are less than 1 year. They also have a significant delay and increase in incomplete presentations in that. And this was a very old article from US, which was for children with less than 1 year. They also showed that there was higher risk of coronary abnormalities in these kids, especially less than 6 months of age. So what has changed over years is the case definition that AHA in 2004 actually defined infants with less than 6 months having 7 days or more, fever of 7 days or more, without any other explanation, to actually investigate for the possibility of Kawasaki disease. However, in 2017, so any prolonged fever with irritability or unexplained aseptic meningitis or unexplained culture negative shock, cervical lymphadenitis or phlegmon. However, again, we do not have a exact criteria even till now, because in 2024 also the update has not mentioned much about it. So also, is it actually sufficient? The AHA criteria, is it sufficient enough to diagnose this? Because we also have children who can present without fever. There have been multiple reports across the world in infants, especially who present without even fever, or maybe a short duration of fever, like 3 days or less. So in these kids, they have been detected to have coronary aneurysms in follow-up, like in the 2nd or 3rd week. So, coming to the Japanese guidelines, actually they mention fever without much emphasis on the duration of the fever, and fever is one of the principal features of the in the criteria. So, they suggest if there is 2 or less principal features, and if there is any enlargement of coronary arteries during the period that we see, we have to think about Kawasaki disease and possibly initiate treatment for that. Again, this has got a caveat, because in country like India, where there is lot of resistance to acceptance of diagnosis of Kawasaki disease, especially in the peripheral settings, and when the children come with fever for 3-4 days with some focus like some cough or something, how many of these patients would need consultation with the pediatric rheumatologist? Will they be actually referred to a pediatric rheumatologist? Will the patient be able to afford a pediatric echo during that time, or whether that will be a financial burden? This is all what we have to take a balance of. And these are the challenges that at least I faced during my residency. The child is extremely irritable and have got high heart rates, and this actually and also when there is tachypnea which is actually added to it, there is a lot of movement, and we won't be able to point out how much of the aneurysms actually. And one more thing which would affect is the narrow costal window, that is actually very difficult. You will have to manipulate the child, and by the time you manipulate, the child will open his eyes and starts crying. Again, it actually makes us difficult for us to assess the coronaries. So also there is a difficulty in visualizing the distal segments, especially in infants, and also pediatric expertise are not available in the periphery. So these are all the challenges, and again we have to balance, and finally it is probably to the clinician to decide and to cater the investigation for each. It should be a balance. So infants have got higher risk of coronary aneurysm, especially those less than 6 months have got about 70% chance of developing a coronary artery aneurysm. So again, they have higher incomplete presentations, higher giant aneurysms also. Same thing has been reflected by various studies as well. And this study which has clustered, possibly talked about in the last few days, have also shown that young age at presentation have got, especially the youngest of them, they have got highest risk of coronary aneurysm, and we can predict it with a high platelet count, probably high percentage of neutrophils, or increased or fall in hemoglobin, as in our first kid who had hemoglobin of 5.2 at presentation, which actually led us away initially. But these are the cases where we'll need to take decisions immediately and possibly start treatment. So coming to the treatment has been covered in the past past four speakers. However, I will be just brushing through it. So basically in the latest update, it has been added that high-risk children less than 6 months of age or those with SAN score more than 3 need primary intensification of the therapy with infliximab corticosteroid. However, this slide has been adopted from one of the previous slides. So unfortunately, we don't currently have any head-to-head trials or RCTs to actually say whether it will decrease the chances of aneurysm in follow-up when compared to those who are more than 1 year of age, where we have definite evidence that possibly it will reduce to less than 1% with primary intensification. So this is something which we'll have to think about in future. So to summarize, KD in infant tends to be very severe. They have unusual presentations, so we need to have a high index of suspicion in each patient whenever they have a prolonged fever, especially along with irritability, and they have a high chance of developing coronary artery aneurysm, and they give a very short window to treat before they develop a huge ballooning aneurysms. So primary intensification of therapy is needed in these children because they come under high risk. Thank you.
Can I request Aparna and Manish also to join Pallavi, and we can have a few questions. So, KD shock syndrome will always be a difficult diagnosis because these children are being managed in another unit and they would have their own perspective. And you would notice that several patients with KD shock syndrome have aseptic meningitis. So if a child is in the ICU and he has features suggestive of aseptic meningitis, that is very likely to be diagnosed as bacterial meningitis. And if you go and tell them that this child has AD when the CSF is not clear, no intensivist is going to accept it that easily. The problem with infants is that not only do they have very severe disease, but the presentation is almost always incomplete. So when you have a young child who is febrile, who is sick, and who has some features of Kawasaki disease but not all, and he may be in some other unit, diagnosis is not very easy to make. And not only do you have to diagnose these children early, you have to be very, very aggressive with management. So these are two of the most difficult situations that you can ever come across. And if there are any questions on yeah, Dr. Puneet first.
Excellent talks by all. Two questions. One is when you say intensification, what do you mean exactly by the sequence? I mean, it will be IVIG plus steroid, then you add infliximab or steroid or cyclosporine, or you add all these three together. So, any clarity on that? Or is it a unit-wise choice?
It's predominantly a unit-wise choice, but generally we prefer infliximab before IVIG because it reduces the reaction of IVIG also. So if we
same day, same city.
yeah, generally we give infliximab, that will be over 4 hours, then we will start IVIG.